pulmonary boards as well. So first of all, regarding the epidemiology, annual incidence is estimated that there was 215,000 cases. This was numbers back in 2009. It's about that per year since then, about 200,000 cases. Annual deaths estimated at about 160,000. It's the leading cause of cancer deaths in men and women in the US, and actually beats the next four cancers combined. The 5-year survival overall is 15%. 1 to 2 million deaths each year worldwide. So you can see, unfortunately, prognosis is still quite poor for overall for lung cancer. At diagnosis, the mean age is 70 years. Only 16% of all the patients are resectable and can undergo surgery. 55% are diagnosed at stage 4, and greater than 95% of the patients who present with symptoms of the lung cancer will actually die from that disease. So when you break it down between female and males, you can see that it's there in green. It's been increasing in females. This is due to increase in smoking, especially in the 1980s and 1990s, where it was decreasing in the males. Although overall it's still higher than the next 4 types of cancers. Regarding the risk factors, as you know, tobacco is the major risk. 80 to 90% of cases has a dose-response relationship. There's greater than 20 known carcinogens in tobacco smoke. Passive smoking makes about 5% of the overall cases. About 25% of lung cancer are in non-smokers, and spouses of smokers have a 2 to 3-fold increased risk of lung cancer. Radon makes up about 1 to 5% of cases and explains about 2 to 3,000 cases in non-smokers. Additional risk factors include asbestosis. The risk increases when there's smoking on top of asbestos, history of asbestosis. Also, there's an increased incidence in COPD patients, IPF patients. HIV is a risk factor, especially for adenocarcinoma, and they have also shown some genetic predisposition as well in patients. So regarding the cell types, non-small cell makes up about 80 to 90% of cases, whereas small cell is 10 to 20% of cases. The small cell, typically oat cells you see on pathology, they have large nuclei and stained blue for hematoxylin and eosin, and they arise from neuroendocrine cells. They are strongly associated with cigarette smoking, and typically they present with large, bulky mediastinal disease. Non-small cell, and you'll see on the reports as well, they'll do specific stains, and they typically are CK7 positive, CK20 negative, that's more colon cancer, TTF1 positive in 75% of adenocarcinomas, and regarding squamous cell, they usually stain positive for P63. Regarding when you break it down into subtypes, squamous cell actually used to be the most common back in the 70s and 80s, but now that's been overtaken by adenocarcinoma, where that makes up 30 to 40% of the cases. It's the least closely associated with cigarette smoking. 50% have never smoked. At the time of diagnosis, 80% present with metastatic disease. You also have a subtype of adenocarcinoma known as bronchoalveolar, and this can be broken down further into mucinous and non-mucinous. The 3 classic ways it presents are a pneumonia-like pattern with a lobar dense consolidation, multifocal with bilateral disease, and also within a lung nodule or scar. They're typically PET negative because they're slow growing, and usually just spread locally and you don't get distant metastasis. Squamous cell makes up about 20 to 30% of cases. 95% of them have been smokers. 60% present with metastatic disease. Large cell, which is not as common, only makes up about 10%. You can get the poorly differentiated form. It can cavitate, and if it expresses the neuroendocrine tumor markers, it's typically less responsive to chemotherapy. Carcinoid makes up about 1% of all lung cancers. You have the neuroendocrine phenotype. They grow slowly. They again are typically PET negative, You can get endobronchial lesions. They rarely metastasize, and usually surgery alone is needed for treatment. So as you said, adenocarcinoma is typically your peripheral lesion, and a large percent of them, unfortunately, will present with metastatic disease in the mediastinal or distant disease. Squamous cell, you see on the left-hand side the classic reverse S sign of Golden, where you have a large hilar mass that's causing endobronchial compression. You get distant atelexis. It can cavitate, and as I said, it's usually more central and hilar. Just a few words on pulmonary carcinoma, because of course it's not that common. They love asking about it on the boards. It's about 20 to 30% of all carcinoid tumors. There's two types, and the typical is far more common than the atypical at 4 to 1. They can present as an endobronchial lesion, which you can see on, it didn't come out too well, on the bottom left as an obstructing mass. They can also present with hemoptysis because it can be very hypervascular. 25% of them present as a peripheral solitary pulmonary lesion or nodule. Less than 5% present with carcinoid syndrome, where you get the flushing, diarrhea, and bronchospasm as you require hepatic metastasis. You can actually just typically diagnose them by their appearance when you see it on bronchoscopy. They have a typical pink to red vascular mass-like appearance. Treatment, as I said, it's surgery, and they look for 5mm surgical clearance in the margins. Prognosis is very good overall, but it's better with typical, with a 5-year survival of 87 to 100%. Atypical, not as good, at 30 to 95%. There are no guidelines for the post-treatment surveillance, but usually what they say, if it's atypical, you do it more frequently at 6 months with history exam, CT chest, plus or minus bronchoscopy, and 12 months for typical. So just regarding the staging of that, if you guys can get a hold of this book, it's actually very good for keeping up to date on the staging, especially the 7th edition for non-small cell that came out in 2010. It's a good book to refer to. So for small cell, the way we stage that, it's either limited or extensive. Limited is when it's confined to one hemithorax and can be included in a tolerable radiation field. 1/3 of patients present this way. However, many have subclinical mets, and that's why they present later with recurrence. Extensive is obvious metastatic disease either to the contralateral lung or distant mets. Regarding non-small cell, we use the T&M staging. The 7th edition, as I said, came out in January 2010. It's important to know the general staging. It can be difficult to memorize, and it's good to refer back to the book. Some general rules, as I said, it uses the T&M. If in doubt, we use this, of course, to come up with a treatment plan. So if you're not sure, we always use the lower T&M classification to give the benefit of the doubt to the patient to give the most appropriate treatment. With simultaneous tumors in the lung, we classify the one with the highest T category and indicate multiplicity or number in parentheses. It aids in the planning of treatment but does not dictate it, and it, of course, can give us some indication of prognosis for the patients and their family. So, regarding the staging, first of all, regarding the T, that's been the major change compared to the 6th edition, and basically size matters. They've broken it down even further. T1 is broken down now into T1A and T1B, depending on the size, as well as T2A and T2B. And they've reclassified T2s greater than 7 centimeters, which are now T3. The old criteria for T2 remains unchanged, however, where it's still a T2 if they have invasion of the visceral pleura, involvement of the main bronchus less than 2 centimeters from the main carina, or if they get atelectasis or obstructive pneumonitis extending to the hilum but doesn't involve the entire lung. So there you can see it mainly the size from 2 to 3 and then greater than 3 centimeters for T1A and T1B. T2A is where it's larger in size and can get some partial obstruction, or it's up next to the carina. For the other changes regarding T3 and T4, if they have additional nodules but they're in the same lobe, that's now a T3 where previously it was a T4. If they have additional ipsilateral nodules in a different lobe, it's classified as a T4 where previously it was classified as an M1. The other big change as well is if it involves the pleura with a pleural effusion, it's now an M1A where previously that was a T4. T3 is determined by size and invasion and or presence of satellite lesions. So size, as we said, greater than 7, where previously it used to be a T2. And now if there's invasion of the main bronchus less than 2 centimeters from the main carina, the chest wall, diaphragm, phrenic nerve, mediastinal pleura, pericynum, and if they got atelexis or complete obstruction of the entire lung, that's a T3. T4 is basically if you've got anything, well, we basically say any important structures such as the heart, main carina, great vessels, trachea, recurrent laryngeal nerves, so they'll have presented with hoarseness. If it involves the esophagus, vertebral body, or a separate tumor but in a different ipsilateral lobe. So the end component is still the same. A T1 is where you get ipsilateral peribronchial or ipsilateral hilar lymph node, and that's at least that's stage 2A, which you can see here on the right hand side. And N2 is where you have subcarinal involvement, which we know, which we call station 7 on EBUS, or if they have ipsilateral mediastinal lymph nodes. This, when they have N2 disease, makes them at least a stage 3A. You can see it there where subcarinal is now involved, or ipsilateral mediastinal. N3 is where you got contralateral, so the other side of the mediastinum, hilum, scalene or supraclavicular on either side, and that's at least a stage 3B. And this is important for treatment down the way, which we'll discuss. And then the M component is now broken down into an M1A or an M1B, where you have contralateral nodules or pleural dissemination, and M1B is obvious distant mets. That's the M1B. So then they break it down basically when we find out the T, the N, and the M, we can then stage the disease, and that will help us come up with a treatment plan for the patient as well as the prognosis. So for the prognosis, a 5-year survival for non-small cell, stage 1A is 65%, the ones who can undergo surgery. Stage 1B is almost 60%, but as you see, as they go further down the stage, it gets worse, and a stage 3A is 23%. The median survival for untreated metastatic advanced non-small cell is 4 to 5 months, and the survival rate at 1 year is 10%, so you can see it's pretty dismal. So regarding treatment and coming up with a treatment plan, it's extremely important at staging the mediastinum. Mediastinoscopy was considered a gold standard with a sensitivity of 70 to 75%. 2% risk of morbidity and less than 1% risk of mortality. Other ways, of course, that we can assess the mediastinum include imaging, conventional TBNA, ultrasound-guided via EBUS or EUS, or as well surgery by VATS or thoracotomy. So looking at the accuracy of CT and PET scan, there's a meta-analysis looking at 35 trials for CT and 44 for PET. You can see there the sensitivity is pretty bad for CT at 51%, specificity at 86%. Better with PET, but still not great sensitivity at 74% and 85% specificity. So the recommendations from the ACCP regarding the staging in patients with enlarged discrete mediastinal lymph nodes on chest CT, further evaluation by looking at the mediastinum should be performed. In patients with obvious results and uptake on PET scan, further evaluation of the mediastinal with sampling of abnormal lymph nodes should be performed. So as we said, that's the gold standard. False negative rate is about 10%. The downside for this is you're unable to reach certain lymph node stations such as 5 and 6, which are between the AP window, although they can get to it via Chamberlain procedure. Also difficulty getting to stations 7, 8, 9, 10, and 11. That's basically down around the subcarinal area and then between or next to the esophagus. It's an invasive procedure, still with a morbidity of up to 2%, expensive, and it basically patients who can't undergo this for comorbid conditions can't have it done. So that's why EBUS has become more and more popular in the last couple of years, where via ultrasound, using a bronchoscope, we can obtain a number and sample a number of the lymph nodes. The stations that we can typically get at, station 2 and 4 are paratracheal, station 7s are subcarinal, station 10 and 11 and 12 are further down, where 10 is hilar, and then 11 and 12 are further down in the airways. As you can see, there's certain ones that we still can't get via EBUS. 5 and 6 are in the AP window, and station 8 and 9 we can actually get via EUS. The GI physicians can get to them. So regarding experience to date, there's been a large body of data, over 300 publications. Looked at 11 studies with over 1,000 patients that met criteria to be included in the study, and what they found is the overall sensitivity is 93% and specificity is 100%. So regarding the treatment, and that's why it's a good idea, you guys. None of you are assigned to the thoracic meeting that we have on Tuesday mornings, but it's actually good to go for just the first hour. We go over the CTs, pathology, and then a treatment plan. You get to see some interesting CTs, and then there's debates a lot regarding patients, and the best treatment plans come up, and sometimes it can be hard to stage them. So the more you hear from this meeting, the more you realize how difficult it is regarding treating certain groups of patients. But it is a combination of the surgeons, the radiation guys, and oncologists. For small cell, as we said, limited, the median survival is 15 to 20 months, and 5-year survival is 10 to 12%. Extensive is, of course, worse, with only a 5-year survival of 1 to 2%. If they have poor performance status and weight loss, it's been shown from studies that their survival is worse. Unfortunately as well, greater than 2/3 of them present with metastatic disease. In the very, very rare circumstance where a patient presents with just a solitary pulmonary nodule, either T1 or T2 with no nodal disease, surgery can be an option in selected cases, and that's followed by platinum-based chemotherapy. In limited, it's a combination of radiation and chemo. But they have to fit the one radiation port that you're trying to include contralateral, mediastinal, and subclavicular lymph nodes or effusions if possible. 80% of patients treated with chemo alone will develop local tumor recurrence. And so in a meta-analysis, by using the combination of radiation and chemo, it was showed to improve survival, and you were also found to have better local control, but it does unfortunately have increased toxicity. For extensive, it's just chemo alone. Prophylactic cranial radiation we use to decrease the incidence of brain mets and prolong survival with both limited and extensive small cell who initially respond to their first treatment. So as I said, performance status as well as age is extremely important in these patients for non-small cell and small cell when you're coming up with a treatment plan. These are two performance scales that we use, the ECOG or the Konorski status scale. ECOG 0 to 2 up to 2, or if they're greater than 70 on the other scale, we can consider chemotherapy. Anything higher, the patients are sicker, typically bedbound, and they basically would die from the toxicity, so it's usually palliative care in those cases. In small cell, response rate with first-line chemo is actually excellent, with greater than 80% response. Typically use a platinum-based chemo regimen, either carboplatin or cisplatin, and from studies it's been shown that combination chemo agents are more effective than single ones. It's usually combined with etoposide, and the treatment is usually for 4 to 6 cycles, which is over 4 to 5 months. Maintenance chemo beyond this just adds toxicity and cost without benefit. So progression-free period for limited is usually about 12 months after the chemo, whereas extensive is worse, just about 4 months. And which is not surprising. When a relapse does appear, the prognosis is very grim, with a median survival of only 3 to 4 months. Regarding further treatment, if the relapse is greater than 3 months, they typically try retreatment with the same induction chemo, and the chance of a second response is only about 50%. If the relapse is less than 3 months, and if they're in pretty decent condition, they'll try a second-line regimen, either single or combo, depending on how sick the patient is. But unfortunately, the response rate is only less than 10%. So for non-small cell, just some general rules. If it's earlier on, if it's a stage 1A or 1B, it's typically surgical resection. 2A or 2B, it's surgery plus or minus radiation treatment. For stage 3A, these are the difficult cases where we treat some of them with surgery, some neoadjuvant chemo followed by surgery, and for some, just chemo and radiation alone. Stage 3B, except for when they have a T4, it's typically chemo plus or minus radiation, and we try and do it concurrently if possible. Stage 4 is either chemo or best supportive care. So if the diagnosis is stage 3 or 4, there's only a 15% survival rate of 5 years, and which is not surprising. If it's much earlier, it's much better, with an 88% at 10 years. 92% survival rate if they've immediate removal of the small lesion. However, only a few patients, about 16%, are diagnosed at an earlier stage. So the ones who are not surgical candidates, either they have bad COPD, we'll consider giving them radiation therapy. Looking at the numbers, at the data, this was like in the past 10 years, it was still poor radiation therapy, just about 20 to 30% 5-year survival. However, there's been big advancements in the way they treat the patients, and there's this new system that's called stereotactic radiation, or CyberKnife, and this allows precise targeting and delivery of radiation therapy, where therefore you can increase the dosing and include a real-time motion management system, thereby decreasing toxicity to the surrounding tissue. And most recent data, there's actually a number of ongoing studies showing a much better response rate giving this type of radiation therapy. So when we're evaluating patients for lung resection, given the high prevalence of COPD, we do spirometry for them all. If the pre-op FEV1 is less than 2 liters, or less than 80% predicted, we then calculate the post-op FEV1. If it's greater than 800 milliliters or greater than 40% predicted, this suggests the patient can undergo resection and do fine. This you can't even make out, but the most important thing I just wanted to point out, and typically like to ask it on the boards, is when the FEV1 or the DLCO is less than 40%, and those are the patients that have been shown to do poorly from surgery. We typically at that point will consider doing a cardiopulmonary exercise test, and the general rule is if it's less than 10 millimeters per kg per minute, you cannot proceed with surgery. And that's roughly the equivalent of walking up one flight of stairs. And actually, some surgeons will do that in the outpatient center when they see them, is take them on a walk and see if they're able to make it up. But they do ask this on the boards. Yeah.
So they are pre-operative assessment, they are not doing perfusion of the scan, they take this FEV1?
Yeah, well, if it's borderline, we will do that to calculate the post-op FEV1. And if it's greater than 40%, that's fine. If it's less than that, that's when you'll consider doing the cardiopulmonary evaluation. And if they do poorly on that, you won't proceed with surgery. Regarding the surgeries, there's also been advancements in that in the last couple of years. They basically do the minimal operation encompassing all the known areas of disease and then try and preserve the rest of the lung function. So you'll hear them doing wedge resections, segmentectomies, or sleeve lobectomies. That's where they remove that part of the lung and that part of the segment of bronchus and then reattach the distal bronchus to the upper airway. However, pneumonectomies are still required in about 10 to 55% of cases. There's careful intraoperative staging performed. Frozen sections of biopsies are sent right away to be read, as well as lymph nodes. And in certain patients, we do more aggressive resections, including chest wall, diaphragm, and occasional portions of the atria. If possible, they try to sample the ipsilateral mediastinal lymph nodes looking for N2 disease so that they can be further staged. There are some exceptions, especially around stage 3A and 3B, when they have a T3 and one M0. These patients, even though they're staged as a stage 3A, the guidelines suggest that we should treat them as a stage 2 and be more aggressive with the surgery. They are, however, grouped as a stage 3A because, unfortunately, their 5-year survival is in keeping with stage 3A at 30%, whereas you can see stage 2B and 2A are much better at 40 to 55%. Another exception is for stage 3B, where it's a T4, any end stage, but M0. Surgery is appropriate in a few cases where they either have a satellite tumor nodule in the primary lobe or cardinal involvement. And in these cases, we're just a bit more aggressive with surgical resection. Regarding Pancoast tumor, so these are the ones that are in the apex. They classically present with shoulder pain, Horner syndrome, weakness and atrophy of the muscles of the hand, where they have involvement of CA-T1 of the brachial plexus. It's an uncommon presentation and only makes up about 5% of the non-small cell lung cancers. These are slightly different regarding the treatment plan. They typically get neoadjuvant chemoradiation followed by surgery, so a tri-modality approach. And this, if we can do this if they've no evidence of mediastinal nodal involvement or distant mets. The 5-year survival with this treatment is 40 to 50%, and treatment-related death is about 4%. So after surgery, you always wonder regarding the guidelines and how you should follow these patients regarding surveillance. There's multiple organizations that came out with different ones. They typically say 3 to 6 months. The ACCP say every 6 months they should get history, physical, chest x-ray, or CT. They typically do that for the first 2 years, and after that it's yearly. You, of course, have exceptions, and some patients, when they present, might have these tiny nodules in other lobes that we want to keep a closer eye on. So for some patients, we do follow closer and with CTs every 3 months. So regarding advanced non-small cell, the median survival is 8 to 12 months. With treatment, we only extended an extra 3 to 4 months, looking at the data in the last 10 years. 1 year survival is only 33%, and it's 10% if they don't get any treatment. And this must be weighed up against a 3 to 5% risk of chemo-related death and they usually die from infections when they get neutropenic. So for stage 3B and for some 3A, they undergo concurrent chemoradiation. From this study, it showed that they have better survival when you treat it with concurrently, although side effects can be worse, especially severe esophagitis. The chemo agent is typically combo with cisplatin and etoposide. For stage 4, combo chemo is better than single agent, and some regimens there are combo platinum with paclitaxel or cisplatin with gemcitabine. They typically do 3 to 4 cycles, possibly up to 6, but you have to weigh up the toxicity, and you want their ECOG performance status. Well, you have to make sure, again, with their age, comorbid conditions, and their performance status, and weigh up the risk of toxicity, and in some of the patients, they'll actually consider this a single agent or just palliative care. If they fail second-line agents that they've looked at, there's a Taxol. It's been shown from some data that there's a 10% response rate. Median survival is improved by about 2 to 3 months. So with these patients, they can unfortunately have some metastatic disease that's causing a lot of pain, especially to the bone, and we'll consider radiation therapy in these patients. It provides pain relief in 80 to 90% of cases, and they can give further radiation if the pain recurs. It's also been shown by giving bisphosphonates to these patients, it can decrease skeletal-related events such as fractures. Also been shown to have a longer time to develop these complications and reduce bone pain from the Mets and improve their quality of life. We also consider ortho intervention, especially in the long bones. If there's greater than 50% erosion of the long bone cortex, if the metastatic lesion is greater than 2.5 centimeters, or if it's in a high-risk area, such as the top of the femur, we'll consider either rods or some sort of internal fixation. So the kind of advancements that have occurred in the last couple of years regarding agents that we can give, especially for non-small cell, they've looked at specific pathways and abnormal pathways that are seen in the tumor cells, especially the ones with overexpression and mutations, as well as looking at the blood supply of the tumors where they develop neoangiogenesis. And by looking at these pathways, they were able to discover a number of medications that can target these specific lesions. You can see there are multiple ones there. The ones that we're going to have a quick look at include EGFR mutation, KRAS mutation, and ALK fusion gene mutation, which these ones we've developed a number of medications, and the recent studies and data have shown good results. So looking more specifically at the tyrosine kinase receptor, the tumor growth and progression largely depend upon the activity of cell surface membrane receptors that control a number of pathways in the cell, which control apoptosis, angiogenesis, and by targeting these lesions, we can switch off these molecules. Another big one that's a downstream signaling molecule is KRAS, and basically by targeting these lesions, we can use new medications. The incidence of EGFR mutation is about 10 to 15% in non-small cell. They found that the mutations are on the first 4 exons from 18 to 21. The commonest one are a deletion at 19 and at 21. They initially, a couple of years ago, gave this agent to everybody, but they found that it was only in a specific group, especially if they were female, Asian, never smokers, or adenocarcinoma. The response rate was much higher in these cases, up to 65 to 75%. they have the older generation, such as erlotinib, but we have newer ones where they actually have irreversibly binds to inhibits the entire family of that receptor. Some known side effects include GI, rash, and stomatitis. These agents have been approved for second-line therapy in advanced non-small cell, but currently they're also being evaluated for the initial therapy in selected patients. And right now the NCC guidelines say that everybody should be tested for EGFR mutation in all non-small cell except squamous cell. So regarding the ALK fusion oncogene, this is typically in adenocarcinoma patients. They're usually the ones that have never or some light smoking history, female at a younger age. The incidence is only about 4 to 5% of non-small cell. We diagnosed it by FISH probe, and they came out in August of 2001 with an ALK inhibitor. The dose is 250 BID PO, and two recent multi-center single-arm studies showed that overall they had a response rate, either complete or partial, of 55%, and this was largely achieved in the first 8 weeks. A couple of side effects that they can develop include visual disturbance, GI, abnormal LFTs, and a very small percent of patients can develop pneumonitis. This was actually just a recent study where they showed benefit targeting specifically the KRAS mutation. It's typically in about 20 to 25% of non-small cells. It inhibits the protein MEK signaling, which is a downstream pathway. And in this randomized controlled trial where they combined it with chemotherapy versus a placebo, they noticed a rate of response of 37% and also a prolonged progression-free survival of 5.3 months compared to 2.1. Avastin is also a medication that's come on the market in the past number of years. It's a humanized anti-VEGF monoclonal antibody where it's targeting basically the angiogenesis of the underlying tumor. And it's been shown in a study that addition of this to carboplatin and paclitaxel, it conveyed a 2-month survival benefit compared to chemo alone. The one important thing, and I remember they actually asked it on the boards, is you can't give it if there's a history of hemoptysis, and also if they have squamous cell. A lot of the ongoing trials will actually won't include it, the squamous cell carcinoma. Other things that they've looked at tailoring therapy. This is a DNA damage repair gene, the ERCC1. By checking this on the tissue samples that we send to pathology, they basically show from studies that if you have an overexpression of this gene, that it predicts resistance to cisplatin, so the oncologist will decide to give something else. Another pathway necessary for double-stranded DNA repair is RRM1, and if they've been shown if they have a higher expression of that, it correlates negatively with gemcitabine, so they usually avoid that in those patients. So just quickly on lung cancer screening. So regarding all the data, who in this room would consider setting up lung cancer screening? Just on the recent data we've had, especially in LST. Would people say yes or no? So yeah, they looked at a certain higher incidence group between 55 and 74. But as you can see, actually I pulled a lot of this from the web. A lot of patients are setting up a lung cancer screening center just going by the recent data. You probably heard the big hullabaloo over the NLST. There's been 2 other smaller studies in Europe. Actually, let's look at them here. The one in Denmark, and the other small one just above that. these are all the recent trials. The one at the bottom, the Nelson one, is ongoing in Europe right now. That's more on the same scale as the NLST one. So that's where it all came about. Basically, this study, the results of it came out last year. They looked at over 50,000 patients, and they showed that low-dose CT scanning reduced the risk of dying from lung cancer in heavy smokers by 20%. There was an absolute risk reduction of 0.33. That means basically 320 high-risk people needed to be screened to save one life. Nodules requiring follow-up were found in about 20% of individuals in each round of screening, and they found about 1% had lung cancer. 2% of the patients ultimately found to not have lung cancer underwent an invasive procedure. Major complication rate was about 33% per 10,000 among those screened. But the questions you have to ask are, they had a huge amount of false positives. You also have to look at the harm to the patient from radiation exposure with the CTs and also complications of diagnostic procedures. Of course, unnecessary anxiety in the patient, the general cost to the healthcare system, and also just generalizing the results. As I said, they screened high-risk patients between 55 and 74, so then people are asking, well, what about older patients and that? Patients between 40 and 55 who are diagnosed, should we be screening those or not? But even with all those questions, these following organizations, NCCN, ACCP, ASCO, and ALL, have all come out with guidelines, although after saying that, they give it a grade 2B, which is weekly recommended. So it's still kind of up in the air, but you're finding more and more hospitals have set up screening ones, and there's actually a push here at Loyola to do it as well. So we'll see what happens. And these are the guidelines that came from that. So it was either current or former smokers between 55 and 74. If they had a smoking history of at least 30 pack years, no history of lung cancer in the past, and basically they then, a lot of these patients say that you should be referred to a facility that uses the best practice with a multidisciplinary approach, and not just out in the community. But a lot of the time, the first thing we have to do is just focus on them quitting smoking. And that's it. Any questions?